Welcome everyone to today's installment of our Summer Roundtable Series. I'm so thrilled to welcome you to the second session of ASTARISQ, or Addressing Systemic and Structural Racism to Improve Safety, Quality, and Trustworthiness in Health Delivery Systems. I'm thrilled today to introduce our two panelists, Dr. Claudia Baquet and Kendal Whitlock, to talk about achieving equity, diversity, and inclusion through decentralized clinical trials. Dr. Claudia Baquet is a physician scientist and former professor of medicine and associate dean for policy and planning at the University of Maryland School of Medicine. She has over 30 years of experience leading health disparities research, including the development of the NIH's first extensive racial and ethnic descriptive cancer statistics program. Kendal Whitlock is joining us from Walgreens, where she is the head of digital optimization, real-world evidence clinical trials, and has over 20 years of experience in the pharmaceutical industry, including clinical development and medical affairs, market access and business innovation, and global clinical operations with a focus on digital clinical trials. Claudia, decentralized clinical trials, what are they, and can you provide a couple examples of what they might look like in the real world?
Yes, with decentralized clinical trials, some or all of the trial activities occur at sites other than the traditional clinical trial research site. And the traditional being, for as an example, an academic health center, a large urban university, as an example. And the sites other than the traditional site where DCTs occur could include a patient's home, a local laboratory, radiology department, and pharmacy closer to the home of the patient. Decentralized clinical trials are very patient-centric, and although they were occurring to a lesser extent prior to the public health emergency due to COVID, with the disruption that the pandemic caused and at many levels, including disruption of clinical trial research and new drug development, the decentralized clinical trials rapidly expanded out of necessity so as not to close the progress that was being made in new drug development. And so that's a short version of what a decentralized clinical trial is. And I'd like to say it's not all or nothing. You can have partial activities from the clinical trial design happening in communities, in which case it's not entirely decentralized, but it's called a hybrid trial where there are traditional elements as well as decentralized elements.
Thanks, Claudia. Kendal, part of your role is in digital clinical trials. So can you describe what a digital clinical trial is and how it sort of coincides with the work that we're going to be talking about today?
Sure, and I was just going to ask the question if I could pick up right where Claudia left off to add additional points on what decentralized clinical trials are. So some may be familiar with the process from having been exposed to it, but for those who may not be, some of the aspects of clinical trials in a traditional sense are done by people with pads and paper and pens and paper. However, with a decentralized clinical trial, there starts with an infrastructure, a platform that's made by a technology company, and it has role-specific access for the investigator to communicate with either patients or others in the research team. So that is done electronically. As well, digital health technologies are a big component of decentralized clinical trials in that there could be use of wearables to capture data remotely from people who are in physical locations different from where the research staff are. So some of those pieces make up what decentralized clinical trials are. And so you can start to think then, as we move through this conversation, what exposure people may have had to the use of the technologies in their own lives. So starting with perhaps a computer or a smartphone. Some people may have routine use of a computer or a smartphone. Some people may not. So if the clinical trial requires a telemedicine visit, then the person has to know how to navigate the computer, whether they access that telemedicine appointment via a computer or a tablet or a smartphone. And so it opens the door to things that will be needed in order to support the needs of the population who is starting to participate in a decentralized clinical trial. As well, some people geographically live in areas that we consider broadband deserts. And if people do not have the connectivity, the broadband access in the geography where they physically live, then we have to contemplate the needs of populations. Where are they going to go in order to do that telemedicine visit or transmit data if it can't be done in the privacy of their home? Are there local areas where they could go where that connectivity would be available to them so that that is not a barrier to their interest to participate in a decentralized or hybrid at-home trial?
Thanks so much, Kendal. Claudia, anything to add there?
One aspect of decentralized clinical trials that became very important in the height of the pandemic due to COVID-19 was the ability to do e-consent, electronic consent. Traditionally, it's done face-to-face, but because of the necessity to adhere to public health guidelines for the public health emergency, e-consent has further developed and has been accepted.
Thanks,
Picking
Claudia.
up right there, I would say this is like ping pong now. So if we think about the entire end-to-end process of a clinical trial, during study conduct, the electronic version of the clinical outcome assessment. So rather than doing that as a paper-based exercise with the clinical research coordinator, now those questions, just like the poll that participants here just took electronically, patients would do eCOA or ePROS, electronic patient reported outcomes. And those are things that have to be instructed. Sometimes people may not be as intuitive or digitally savvy to know how to navigate doing those pros on their own. So instruction is very important.
Absolutely. And interestingly enough, for today, in terms of our affiliation, we have 60% identified as academic or clinical researchers. So probably people who could really be inspired and engaged in today's discussion for how do we create diverse, equitable clinical trials and look at the decentralized model for, progressing in those areas. So the next question really is, how do decentralized clinical trials address diversity in ways that are meaningful and authentic and sustainable? So Kendal, turn to you first.
Yeah, I'm glad to just start in on this conversation because it's one that's come up for the last several years, even prior to the privilege to have joined this incredible team at Walgreens under the leadership of Ramita Tandon, who's our Chief Trials Officer. That question persisted, and it's part of how I got involved in digital clinical trials in my former employer. And that came up as a possibility for me professionally when the components of decentralized clinical trials, when one thinks about traditional clinical trials in the brick and mortar facility, we know from the evidence that trial sites are often up to 2 hours away from where people live. So one barrier to participation for any person, not just racially or ethnically diverse populations, but for any population, is that they're hard to reach. They're physically hard to reach. We also know that there are issues of mistrust or distrust from historic atrocities against certain populations, subsegments of the population. So that issue is also one to address. Other barriers to participation are not only from the patient point of view, but from the provider point of view. A lot of clinicians, a lot of primary care doctors, for example, don't do clinical trials as a part of the way that they practice medicine and the activities that they do. So if your doctor is not one to invite you or to educate you about the possibility of a clinical trial in the context of managing your illness, or you're a caregiver for someone who you are with them in an appointment, if your doctor does not inform you about the possibility of participation in clinical trial, then where are people to go as a trusted source from which to have that conversation, to have that first exposure? So there are other segments. I mean, there are barriers from the sponsor perspective, who has timelines, tight timelines, regulatory standards, et cetera. And even from other sites' perspective, the infrastructure in a traditional clinical trial site was not set up with digital capabilities across the board. There is more than one decentralized clinical trial owner, manufacturer. So there are multiple technologies to learn about. So if you're a site and you're trying to get up to speed on not just the availability of decentralized clinical trial platforms, but multiple decentralized clinical trial platforms and all of the complexity of each one, then that's a time commitment on behalf of the sites that then has to translate to the experience overall that patients are going to have. So one way that the digital pieces start to address some of the historic barriers to participation, starting with distance. One of the reasons I was so excited about what Walgreens is doing is in seeing the commitment from our leadership of the disproportionate mortality and morbidity in Black and Brown communities, and the physical proximity of where Walgreens is located in the United States. And for example, there are 9,000 locations and 78% of the country is within 5 miles of a store. Now we know that there are changes in the environment in different geographies, so stores will close or stores will pop up. But the point being that if almost 80% of the country is proximate to somewhere that they can go that has a private health room, a healthcare professional, that's more of an opportunity that maybe they hadn't contemplated before to participate in a clinical trial. And so in learning of those services, there are other things that through their retail pharmacy, they may be able to learn about in order to manage their own health and wellness. So that's one reason. And more than 50% of our stores are also in socially vulnerable communities. 89% of them, there are data across these locations, but for Black and Brown communities in particular, almost in all geographies, 85 to 90% of them have African American, Hispanic, and Asian populations proximate to where the pharmacy is located. And that is important because those are the subgroups who are often underrepresented in clinical trials. It's specifically 89% of Americans, 88% of Hispanics, and 95% of Asian Pacific Islanders are proximate to the Walgreens store. So if the Walgreens is a point of entry into the conversation about clinical trials, then maybe that's a conversation someone hasn't had before. And the pharmacy is a trusted health professional and an entity in the community that can be conversations with primary care doctors as well as others.
I just wanted to give an example of proof of concept for decentralization of clinical trials in a rural community that I worked in the mid-90s. By way of background, Dr. Sonia Springfield, who heads the NCI, Center to Reduce Cancer Health Disparities, had two funding mechanisms, one special populations research and the other community network program, which were two grants that I had. I had a partnership with a very compassionate and outstanding community oncologist on Maryland's rural Eastern Shore, Dr. Mary DeShields. We developed the partnership to increase availability of cancer trials in rural Eastern Shore, as well as to increase accrual of rural patients, but also rural African-American patients. And if you know the Eastern Shore, it could be as much as 2.5 hours each direction over a bridge for a patient to come to the central site in Baltimore City. And the patient may be very ill, and the loved one taking them, the caregiver may have to take off work and lose income. And so we were highly motivated to develop a comprehensive program to increase availability and accrual to cancer trials. And that included prevention, therapeutic, quality of life trials on the rural Eastern Shore. And our approach was multi-pronged. It had to be. It had to address the fear and the distrust in the general public and in the patient community. And so we had intensive educational programs ongoing with the community about Clinical Trials 101, how to access clinical trials, tell your primary care doctor about your interest in clinical trials. The second area for the approach was the community practicing clinicians, primary care, and some specialty who were very distrustful of the urban academic institution which was the traditional site. And so a lot of continuing education programs on, again, Clinical Trials 101, how it could or could not benefit your patient, what's required, and how to refer a patient to an open protocol when we started having the open protocols. And then finally, to build the infrastructure in rural communities. And Kendal mentioned that the broadband issue. Initially, we were trying to use telehealth follow-up visits so people wouldn't have to go across the bridge to Baltimore. And the infrastructure was in the beginning, it just wasn't there. So we had to come up with a lot of policy and advocacy activities with the Maryland legislature to put broadband in a number of the areas where it wasn't available. So that's the short version of it. Preceded, obviously, the pandemic, which other examples of on a smaller scale of a decentralized clinical trials exist. But it was proof of concept that in a very underserved area on the rural eastern shore of Maryland, that it can be done. And the clinical trials office still operates today with great successes and accrual, as well as data quality awards from the regulatory organizations.
Thanks, Claudia. And you mentioned the word success, which actually dovetails quite nicely into my next question. But I also want to take a moment to encourage our attendees to use the chat or the Q&A for any questions you might have. Certainly, we want everyone to walk away with information that they came wanting to find out. So please share with our panelists what questions you have and what you want answered in today's discussion. But regarding success, how do you define success in a decentralized clinical trial?
Well, I think with any clinical trial, the purpose of the trial in determining the safety and efficacy of the medical product under study and getting through the completion of the trial to obtain that data set is success of any trial, whether it's decentralized or not. So I don't think that success is defined differently per se in decentralized clinical trials. There can be some additional successes, and I think it depends on one's approach to and how they measure success. So for example, if in traditional trials, we know that first, very few ethnic and racial minorities participate in clinical trials in the United States. And we find that if people are not having conversations about what a clinical trial is with a healthcare professional, the recruitment at the time that a trial starts may not be the point in that person's journey to start becoming educated or first aware and then educated about clinical trials. Perhaps in the design of some approaches, and perhaps Claudia, you can speak to this in your lived experience of running those trials using decentralized elements. There was a lot of education upfront and continuously. And I think when there is upfront awareness and upfront education and education available continuously from trusted sources, not the medical center or the facility that the community may not trust, but maybe they trust those who are proximate to them, who they can re-engage as often for questions that they may have. So by first defining what success is, I think some of those success definitions also include learning about the voice and experience, or learning from the voice and experience of actual patients. So if we think about, and we haven't talked yet about guidances that have come out recently, I'm specifically thinking about patient-focused drug development and the regulatory interest to have more voice of patients earlier in medical product development. And those insights from actual people who are living with those conditions are informing protocol designs. They are informing the way that we capture data. Sometimes those who are designing protocols don't have all of the answers on how to design questions. And maybe there are things that patients with the actual condition can help to advise trial teams on, so that protocols don't have maybe such restrictive criteria for eligibility, for example, that would exclude certain segments of the disease population. So success might be getting the voice of patient earlier in medical product development, so that it's not an afterthought after the outcome of a study yields underrepresentation of certain groups. So I would say that having that early is maybe another measure of success.
We recently completed what we believe are two important studies that focus on one of the areas Kendal just mentioned, the importance of the education for the community and for patients. And these two studies, one funded by NIH, the other funded by the Food and Drug Administration, documented community concerns regarding ethics or lack of ethics in research as a contributor to distrust, mistrust, and lack of trustworthiness. And we can have decentralized clinical trials, and I'm hopeful that it will be adopted, even though the public health emergency has been lifted. But you have to do the background work first for the communities, as Kendal mentioned, that are traditionally underrepresented, for example, African Americans. In these two studies, African American participants confirmed their tremendous interest in participating in clinical trials, but felt that clinical trials were not for them, that it was for other non-people of color communities. They felt that there wasn't disclosure and full transparency sometimes when they're approached by an investigator, even though they want to participate. And so in order to address these concerns about ethics, concerns about having results from a trial for the participants and for the public at the end of the trial, and increasingly in recent times, the participants desire to have post-trial access to experimental medications if it's appropriate at the end of the trial, and post-access care. For example, uninsured individuals consent to participate in trials. At the end of the trial, there's no insurance, and it's kind of back to the drawing board. And so there's tremendous concern by the public, African Americans in particular, that there should be guarantees in the informed consent process that, one, they will receive the results. Two, members of these sessions that we had mentioned they were in trials for 3 years, and it's 5 years, two years later after the trial ended, and they still don't know the results. So full disclosure, return of research results, and discussion about the provision of post-study care and access to experimental medications is critical. And while there's the undercurrent of these historic research abuses, the untreated syphilis study in Tuskegee, Alabama, by PHS, the Public Health Service, the PHS Guatemala study, which intentionally infected individuals with sexually transmitted disease during the same time the Tuskegee study was happening. Mrs. Henrietta Lacks, of course, known very well in Maryland and in Baltimore in particular, and with indigenous tribes, the Havasupai against versus Arizona State University, that there are undercurrents. People have memories about concerns about being a guinea pig or research exploitation. However, as a result of ongoing misinformation and poor science communication during the beginning of the pandemic and throughout, individuals attribute their lack of trust and lack of trustworthiness, more so in these two groups, to the miscommunication, misinformation, and not full disclosure. Something as simple as at the beginning of the pandemic, the vaccine will take X number of years, maybe 15 years. And then there were 2 mRNA vaccines, brilliant technology, that were available after 9 months. But it wasn't explained to the public that that technology was there, and we applied it to this different virus. And we are learning things. It was a novel virus, we're learning things, and we'll keep telling the public when things change. The concept of variants and mutations of viruses, I felt, and these members of our group said, it wasn't explained enough why we have to get the basic vaccine, we have to get a booster, but then months later, we have to get this other booster. So, I am a proponent of intensive ongoing education in ethical protections regarding research, clinical trials 101, and making as simple as possible an explanation about a virus and its natural characteristics to mutate which may have an influence on changes in the vaccine that you need to get.
Kendal, anything to add in terms of resources, tools, other means for success?
Yeah, I think Claudia has said it all on that point specifically. I think stressing it, just the ongoing education and ethical protections, I think could be as ubiquitous as the CPR training in our local communities that is available to people. I think that this is foundational. It shouldn't be something that is frightening for people. What maybe is driving fear is just unknown. And so empowerment through education, I think, is just kind of the mantra of the day.
Sure. And we received a question in the chat about what are the best practices to mitigate distrust during recruitment, given all of the historical injustices. So Claudia or Kendal, yeah?
Yeah, I was going to say there is a great paper, and I will find it and put it in the chat, by Stallings et al. And it talked about the trustworthiness scale in clinical research. And this is a team, and I don't know them personally, but I was so inspired in finding this work that they looked at this issue of mistrust and distrust, and they did an analysis among African American, Hispanic, and Caucasian populations, and found that mistrust and distrust is not one thing, and that African Americans and Hispanic populations trend in similar manner in what things they do not trust as a function of. So, for example, communication, honesty, fairness, and there are different domains, and I will send this paper, but they are statistically significantly different than the reasons that Caucasian populations say they may not trust. And so it's really important when we talk about trust or trustworthiness to specify for whom that applies. We don't want to make blanket statements about they, because who is they? We don't want to make statements to say, oh, they don't trust. Well, let's be specific. If under communication is a trigger for some groups, be armed with that knowledge and apply different communication to satisfy and quiet the potential mistrust or distrust in that area. If feeling like the honesty, maybe Claudia, you mentioned earlier that the group in the Eastern Shore didn't feel that people were being honest, and maybe it's because sometimes people use technical language, and when they talk to people who are outside of a professional circle, they may not use the same language or the same terms. And so having that, and you also cited the lack of science literacy, this lack of science education. I think when people don't have a way to communicate, it makes that a trigger for what's going on, because there are gaps in their understanding of what is being shared with them, even in the informed consent process. So I will look for that paper. I'll stop there.
So we've had a couple of questions and comments both come through the chat and the Q&A. So I'll share a couple for you to respond to. The first is there a functional difference between a decentralized clinical trial and a pragmatic clinical trial, or is it a difference in terminology? Can either of you speak to that question?
Well, a pragmatic clinical trial is sometimes called a practical clinical trial, and it will often compare in the clinical trial a couple of different treatments for efficacy and effectiveness. The decentralized trial is related to the design features that allow remote and aspects of monitoring and conducting the trial outside of a traditional research setting, meaning like an academic health center. And again, as Kendal mentioned, these are often miles and miles away from affected communities that are underrepresented.
Our second question is, are there any unique challenges related to monitoring, QA or QC for decentralized clinical trials as compared to centralized trials?
That was one of the concerns during the pandemic, with the massive disruption of clinical research during the pandemic, and then the adoption with guidance from the FDA on conduct of decentralized clinical trials. And so I think for many investigators, there was concern about quality, and ability to implement the trials in remote settings. You know, there are some things, like as I mentioned, it's not a all or you know, one way, and meaning the whole trial is decentralized. But in the hybrid trials in particular, you know, you're going to have designs that respond to the complexity of the disease, the complexity of the follow-up. And so in some settings, in some disorders, a fully decentralized trial is not recommended. So yeah, I mean, it's been stated during the pandemic that, you know, we're rushing to do this, the remoteness, we're not used to doing this for a number of centers. And so quality management was a concern. But we know, for example, that during the pandemic, using decentralized clinical trials, that there were a number of cancer medications that were developed and approved by FDA during this heightened rollout of decentralized clinical trials during the height of the pandemic. So yeah, I think that's a concern.
I think in the beginning of the pandemic, absolutely, I heard rumbling as I was making an attempt to identify clinical investigators for decentralized clinical trials. And if you can imagine the sentiment of the clinical community across therapeutic areas that did not routinely do, for example, telemedicine, did not have an infrastructure of mobile or remote healthcare professionals to go to one's home. So one of the elements of a decentralized clinical trial is having a maybe nurse or a phlebotomist go to the patient's home. Well, that wasn't routine practice, and a lot of sites didn't have that part of their business as a whole remote nursing staff. So there were learnings at the very beginning of the emergency, and those over the period of years, people started to learn, oh, you can do a 6-minute walk test virtually. Okay, so the healthcare professional goes to the home, they log in, they have the investigator on the other end, and lo and behold, there are things that we've never tried before. And so the resistance is a natural one to have heard from the clinical community about decentralized clinical trials very early, because it wasn't routine practice. But the experience that we've had over the last several years has shifted, I think, the comfort with the adoption of the use of these technologies, especially in identifying efficiencies and perhaps ways to aggregate certain study visits where it's clinically appropriate to not have as many study visits during the course of a trial, because some things can be done at the same time as something else. So by shortening, perhaps where possible, the number of visits it reduces the burden on the patient, reduces the burden on the entire team. So the decentralized or digital elements help to facilitate those efficiencies, and in some cases, even cost savings.
I have a question. Kendal, how do you prepare underrepresented communities for application of digital tools?
I'm so glad you asked this question. In the fall of last year, maybe wintertime, but there are several ways and several things that we at Walgreens are looking to do, thinking first through the lens of those who do community-based participatory research, because we know from WHO and from other authorities that has been used successfully, capturing qualitative data as well as quantitative data to change behavior in African American and other communities of color. So first, applying that lens of not thinking that we have all the answers ourselves, but identifying first the opportunity to partner with communities, because if any one entity, no one entity can do it all alone. And so by looking for where we can first partner with communities, maybe community-based organizations, federally qualified health centers, academic medical centers, who have patient populations who may be receptive because that organization is a trusted source of the information that they are engaged in, then looking for ways to partner with those groups holistically and thinking about patients, and you said the term patient-centered earlier, and thinking about how we can create surround sound. And I use that expression of creating surround sound because In the traditional trial, we think about recruitment as a starting point where we have to find our numbers of patients who are eligible against a protocol. We have this quantity, and we go forward with perhaps an email campaign and perhaps followed by a text message campaign. And we don't contemplate what the lived experience is of the bolus of people. Maybe some people are not going to respond to email. Maybe some people don't text, even if they have a phone number. So we have to ask the kinds of questions, and we have to not believe we have all the questions correctly structured. We've got to engage patients who have the lived experience of managing the illness to help to design what it is that we are going to ultimately capture. And so, whether we are going to do focus groups, whether or not we are going to co-create resources, people generally, humans just generally would like to see themselves represented in something that's in front of them. We are human at the end of the day, and not that different from one another. We can call these social terms of race what we will, but at the end of the day, we're less than 1% different, right? So we've got to think about the experience that a person has. We don't contemplate whether or not having that illness causes fear. Just they're contemplating one's mortality, contemplating the cost of taking care of themselves. That could be a concern for people. They don't know if there are hidden costs associated. Maybe there aren't expenses to the individual during the trial, but what happens if they have their disease requires additional medical attention? Is that going to be an additional cost to them? So there are all kinds. Maybe their illness is one that requires a caregiver, and as you talked about, then that person has to take time off work or manage the child care in the home. There are all kinds of reasons and things that people come to the table with. So in a long way of saying, creating the resources by co-creation, not by saying there's a one-size-fits-all in the way that we are going out into communities with educational resources and then iterating on those. We're not going to get everything right the first go out. We have to be able to say, okay, we learned from that one experience what worked, what didn't work. So if this was a medical product development, we would be iterating on a minimum viable product. That could be an educational resource. Maybe it's the right content, maybe it's the wrong channel. Maybe some people prefer the telephone to the text message. We've got to ask the preferences. We've got to understand things like social determinants of health. If you're sending out an email campaign to a number of the population that is eligible for a trial, but don't know whether or not they have housing insecurity or food insecurity or literacy challenges, or maybe they're uninsured temporarily because they've lost employment. We have to contemplate the rest of the lived experience of people as we create resources, and obviously not developing those resources ourselves, but co-creation with partners.
Absolutely. Claudia, any other thoughts regarding the inclusion of people in co-developing the work for them?
Oh, it's essential. It's why we're still today talking about underrepresentation in clinical trials or clinical research in general, and not one, paying enough attention to the public and the community's ethical concerns. We all have these regulatory requirements. There's legislation and regulation, the NIH Revitalization Act, the Common Rule, et cetera. But we still are talking about, despite wonderful efforts and important regulations to protect those who volunteer for research, we're still talking about underrepresentation. Why won't they come to my study? And so I think the bidirectional partnerships between research, academia, and the public are essential because in addition to informing and making relevant what needs to be done in terms of design, recruitment strategies, retention strategies for trials, that it's an essential part of what Kendal mentioned, empowerment for communities, having the knowledge to make informed decisions. And bidirectional partnerships, bidirectional learning, where the public, the patient, and the clinician, researcher, the academic, are in the same training course is essential.
One concern that often comes up, and we hear it certainly in the patients program, is about time and resources. When do I engage someone to talk about my trial? When and how do we pay people or compensate them for the work that they'd be doing to help co-develop our study? And then there's a question about evidence. What is the evidence that this makes a difference in my bottom line for the number of people that I'm recruiting for my trial? So what might you say to individuals who either say, what is the evidence, or, is it really worth my time to do the bi-directional work?
Yeah, I would say easy to ask the question when you are not represented in the community, where if there are 83,000 lives lost due to health disparities, as Satcher et al. Published some years ago, then you may not have the lived experience of why addressing it is urgent. If we see disproportionate mortality and you're going to funerals every weekend and you get to work and people that have not had the direct experience may just be less aware or less sensitized to why it is important to address. So I think that when we come full circle to the investment in the development of resources that are informed and continuous and in need continuously for retention in trials. If we think about the approvals, for example, there's another paper, and I will put in the chat, that came out in May, and it is an actual data visualization. It's a very sophisticated model, and they took FDA trial snapshots, and they populated a tool so that they could look at the representation in each of the studies. Of 80 approvals, 8 of them were in oncology, 1 was in chronic hepatitis C, and I'm drawing a blank. I think the other was HIV, but I will confirm that when I get the link. We saw 96% of African Americans did not achieve, the approvals did not have the incidence of disease. So if African Americans, for example, are not represented in drugs that are approved, then we don't have the scientific evidence of whether or not there is safety and efficacy in those products for that population. That can cause the clinician who prescribes those products to have less confidence in the use of those products for that population because the data are not in the label. Similarly, if the patient population who asks the prescribing doc if this product will work for me and the evidence is not in the label, that patient may not see the relevance of staying on a product for the condition that they have. And it is incumbent upon that relationship, the provider-patient relationship, to support the outcomes, it's not just on the doc, but it's a two-way, right? It's a shared decision-making. And if the patient doesn't know that, or doesn't believe this is relevant, then the cost of managing that illness could escalate. And that will end up ultimately costing society more to manage diseases that are progressed beyond where we could have intervened earlier by managing disease better. So I think, there are upstream needs, there are downstream needs, but ultimately there are continuous needs in this process of trying to achieve health equity, equitable care, equity in research.
Absolutely. Claudia, you mentioned Dr. Mullen's Trust and Trustworthiness article that came out a couple of years ago, which I've now put in the chat. Do you want to share a little bit about why that is resonating in this moment?
Yeah, well, it talks about trustworthiness being antecedent to trust development, and that they're not the same. Trust is not the same as trustworthiness, and it gives an outline for how to foster trustworthiness in the academic component that's trying to establish a bidirectional partnership with community. And I highly recommend it because it gives a realistic and more relevant approach to looking at distrust and mistrust, teaching the individual what steps need to be taken to develop trustworthiness that can, in a long-term way, result in trust. That's the short version.
Thanks, Claudia.
Thank you for putting that in the chat.
Yes, and we have a few minutes left. Certainly, if others in the webinar today want to share in the chat or Q&A resources that maybe you have related to our discussion, or again, any final thoughts and questions that you want to share with the group, we're happy to have them. But in our final moments, I certainly have one question, which is, decentralized clinical trials are still considered innovative. Both of you have shared recommendations for how they can be incorporated into the work that clinical researchers are doing, again, from a central location, or how we can implement new tools to build trust and trustworthiness of bidirectional learning. When you think about, 5 years from now, where do you hope decentralized clinical trials are in, the field of achieving health equity or other components? What is sort of your vision and your optimistic vision, I should say, for clinical research incorporating DCT in, again, achieving equity, diversity, and trust and trustworthiness?
Well, one thing I would start, Claudia, please go ahead. I was going to give you the last word. One thing that I would say is an essential is we've got to get our language right. We've got to decide that if we refer to this as decentralized clinical trials, we in life sciences may understand what we're saying, but the patients and caregivers and in communities may have no idea what we're talking about. And so being able to explain to people that participation in clinical trials can happen in any number of ways. There are many types of clinical trials. And by incorporating the potential for some of the visits to be conducted, not at the traditional study site, but they can be conducted locally, say at your pharmacy or at home, then explaining what the clinical trial is, calling it, flexible and more convenient for people, and getting away from the terminology of decentralized trial or virtual trial or remote trial or this, that, and the third, because that's confusing for people. And in 4 years, we really haven't gotten to the one term that covers it all. So let's just get rid of the term.
Well, I'm hopeful that in 5 years, we'll have, out of necessity, kind of what was missing, which is metrics to show the effectiveness of the decentralized clinical trial method. And that goes with also metrics for, is it addressing inequities in trial participation? Has it increased participation of the populations who are underrepresented today? But that must go with, again, a multi-pronged approach. You have the design folks, you're going to have the metrics folks, but you also need to educate the public about this as a potential opportunity. It may be an opportunity for some patients. It may not be able to be done with other patients because of the nature of their disease and the design of the trial, but I'm hopeful that we'll have more metrics and results about outcomes using the decentralized clinical trial methodology. And you said 5 years?
Mm-hmm. Yeah, I see a question from Daniel in the chat, and I'd like to tackle it just before we close out, if I could. So a couple of things, at least about our approach through Walgreens. So some of the things that I didn't share at the opening and in my intro was the fact that the clinical trials business is 1 year in existence with Walgreens. So we are just beginning our journey of clinical trials. And Walgreens Boots Alliance is a large global organization. Another part of Walgreens Health, has relationships with primary care doctors. Village MD was an acquisition that Walgreens acquired, I think it was last year, and Village has acquired other primary care practices. So some of the other parts of the house, as we say internally, are addressing the reality that when the clinical trials business has an end-to-end experience with our customers, our pharmacy customers, there are 130 million lives served by Walgreens. We don't have to discontinue our engagement with our 130 million customers because they're still going to fill their prescriptions. And that side of the house is aiming to close care gaps in the work that they do. So they are working with their partners, boots on the ground, to address the unmet needs across diseases. So what will happen with our patients, one of the things that is absolutely happening and we're going to continue to do is to survey their experience, what they might have wanted to see done differently. Our aim is to have an experience that is satisfying and is intuitive so that people don't have questions about whether to participate and not participate because of hesitancy. Maybe they're busy right now doing something else, and that may be a reason not to, but certainly not discontinuing their participation or not entering and starting participation because of fear. So if in 5 years we had people who are not in life sciences being able to give an answer to what is a clinical trial, what is the purpose of a clinical trial, where can I go to participate in a clinical trial, who can I talk to about clinical trials? They should have a toolkit themselves that is just like having the toolkit in case of a fire in one's house or a first aid kit in their house, because we as families and in communities prepare for things. And we learned during the COVID pandemic that we were not prepared for that specific emergency. But oh, by the way, Robert Califf held an emergency preparedness White House hosted webinar earlier this year that my boss had the opportunity to participate in, so that across industry, there was a discussion about how do we prepare the country for clinical trial participation if we have another pandemic? What are the things that we need to do? What are the things that we need to know? So if 5 years from now, we have some sort of document that informs communities, and whether that is with your local, from a policy level, we have it all the way down to the local level where through relationships within communities, you will know what a clinical trial, what is the purpose of a clinical trial, who to talk to about clinical trials, where to go to participate in clinical trials. And that will be seamless, so that will be turnkey, and that will be something that we would expect, and starting to see the percentages of people who don't understand and don't know, and direct them accordingly.
Claudia, final thoughts from you?
Well, I'm encouraged by the Clinical Trial Transformation Initiative plan to survey pharma and others about their experiences with numbers in decentralized clinical trial during the height of the pandemic. And this promises to give information on the percentage of, for example, African Americans who said they prefer the DCT design rather than the traditional. So I'm hopeful that we'll have some good information coming from those planned surveys. I know, Kendal, you were going to talk about, I think, Fedora or the guidance. I know you had mentioned that at the beginning.
Yeah, DCT, I mean, there are several guidances, but I think that cutting to the time we have left, I think it's important to know that there have been several guidances that have come out in the last few years. So back in 2020, there was an initial guidance on diversity in clinical trials. At the end of last year, we had the omnibus finally made the requirement for pharmaceutical manufacturers to propose a diversity plan or submit a diversity plan with their registration package. And that is now a requirement. So the organizations are going to have to think about how they are going to address those who are historically underrepresented in clinical trials, including those from different races, ethnicities, etc. I think that digital health technologies also had a recent guidance this year, and we have to think about whether or not people have sufficient broadband in their communities, as we've talked about, and if they don't comfortably use technologies because maybe people can't afford a $1,000 smartphone or don't use wearables routinely in their lived experience, we have to think about the resources that would enable people to take advantage of some of the benefits of the use of these digital health technologies in the first place. With decentralized clinical trials, we also know that even the retail pharmacy was called out in the guidance on decentralized clinical trials to contemplate having a location that's proximate to where people live as a point of entry into clinical trial participation. So I feel like I'm rushing now to get everything said before we close.
And then Dr. Mullins' comment about the importance of leaving something with the community cannot be overstated. And And it includes return of research results and discussions about post-trial access and post-trial care, but it also includes providing ongoing foundation for learning and education of the public about the benefits, the potential risk, how to, as Kendal just mentioned, how to access a clinical trial for you or a loved one. And so that cannot be overemphasized, the importance of leaving something so that we're not replicating what's a concern in many communities, helicopter research. We come in, you're kind enough to consent, you give us your specimens, you never hear from us again. So I'm very opposed to that perpetuation of that unethical way of engaging with the community. And so with that, I'll stop. Thank you.
Of course. And certainly this, I mean, while today's conversation might be coming to an end, it is clearly not the end of the conversation for addressing structural racism in health delivery systems and clinical research. I do want to take a moment to thank both of you, Claudia and Kendal, for participating in today's discussion. And I look forward to continuing this discussion with both of you through this program and the other means in which we get to collaborate with you at the Patients Program. So again, thank you both for your insights today, and certainly thank you to all of our attendees for joining us for today's session. And we look forward to seeing you all again, hopefully next week, for our third edition of the Summer Roundtable Series. Take care, everyone. Thank you.